In this quick video, you will learn about the classifications of urinary incontinence. I'll be going over the many types of incontinence. At the end of this video, you will learn about some tips and considerations for your client from functional to psychosocial factors in occupational therapy practice. Hi, my name is Jeff and I am an occupational therapist. I make occupational therapy content on my blog, ot.dude.com, social media, podcasts, and regularly here on YouTube. If you are interested in learning more about what occupational therapists do, be sure to subscribe to my channel so that you don't miss a single video. Also, check out my free resources in the description below. Let's get functional. You are all probably familiar with the term incontinence. Urinary incontinence may present as a loss of a lot of urine to very little, such as in small dribbles, which may even go unnoticed by the client. Also, urinary incontinence can have causes that aren't due to an underlying disease like you may expect. Some examples include unavailability of bathrooms. Who hasn't experienced that before? ETOH, coughing, sneezing, laughter, even anxiety. So some of your clients may have underlying causes, and combined with these behaviors, it may also cause urinary incontinence. Total incontinence is what it sounds like. The client loses urine all the time in any type of position. This is likely due to a loss of sphincter control and function from causes such as nerve damage or cancer. Stress incontinence is often encountered by OTs when working with clients when they mobilize or perform a functional activity with them. It is also the type of incontinence that happens when you suddenly sneeze, cough, or laugh. Lifting and exercise can also cause stress incontinence. This is likely due to pressure being exerted on the bladder during these activities. Urge or urgency incontinence is the sudden, intense urge to have to go, and then the loss of urine shortly after. Clients experiencing urge incontinence may have urinary frequency and nocturia or nighttime peeing. Causes range from neurological, inflammatory, infections, or diabetes. Overflow incontinence is exactly what it sounds like. The bladder is not emptied completely, and due to excess pressure on the urine inside, there is incontinence. It is related to a chronically distended bladder. Urine often dribbles out. Conditions include diabetes, obstructions, or neurological disorders, including spinal cord injuries. Functional incontinence is a physical or cognitive limitation of the client that results in incontinence. Physical can be things like mobility, strength, balance, that prevent the client from, for example, making it to the toilet, or the inability to get pants off due to something like poor fine motor control is another reason. Psychosocial factors may also affect this, such as anxiety or depression. In regards to cognition, it may be due to memory or problem solving or executive functioning. Conditions such as dementia may impair things like sequencing or self-awareness to have to go to the bathroom. Mixed incontinence is simply a combination of the ones I mentioned earlier, such as stress incontinence combined with urgency incontinence. So, how can OTs help? An interdisciplinary technique that can be implemented with nursing and doctors is timed toileting for severe incontinence such as total incontinence, but it generally works for multiple types of incontinence as well. By prompting the client to go at set intervals, their bladder gets emptied and is less likely to cause an episode of incontinence. This is less helpful with types of incontinence with constant dribbling though. Another compensatory method is to have the client wear, say, adult briefs or Depends. If they wore them in the past at baseline, this is usually not an issue, but if this is potentially a new thing, it's important to be sensitive to the client and their emotional needs. You can also recommend a combination, say, of time toileting and adult briefs, such as in nighttime. The ultimate goal, if due to an acute cause or one that is not chronic, is to have the client self-initiate toileting. Some clients, such as those with moderate to severe CVA, are poor judges of when they need to use the bathroom. I like to prompt clients to try and go anyways in the beginning of the session before doing anything else. You can say, hey, let's try and see, it's just good practice. And you can just wash up in the sink before stepping out and doing our therapy, for example. If clients know or you know they have urgency or stress incontinence, you may want to be prepared and have a urinal ready. Sometimes clients even know they can't make it, and there's really not much you can do other than the urinal in those cases until they gradually improve and work with the doctor and nursing. Making the clothing easier to manage is another way you can promote toileting to overcome functional incontinence. For example, pants without belts, ones that are easier open, such as in the flies. Looser clothing can also help. Addressing the underlying physical problem would help too, such as fine motor skills, gross motor skills, coordination, that kind of thing. Sometimes it takes education, like in CVA, to do it with one hand. Don't forget to practice moving around in the actual environment or a simulated one in the home, like navigating narrow spaces, at night, that kind of thing. Last, I want to talk about nighttime toileting. It's important to stress safety as there is often urgency, so to address drowsiness, falls, orthostatic hypotension, low vision, having good task lighting, reducing clutter around the environment, and not drinking as many fluids before bedtime may help. Some clients may just not make it to the toilet, so a bedside commode, if really urgent, may help. I have no problem with that at all, so work with, again, the doctor, nurses, and nephrologists and come up with a solid plan so that things are consistent and the client is not doing, say, one thing with you and another thing with night shift, for example. If you notice something unusual, it may be due to another cause such as UTI, so be on the lookout for that and communicate with your team. Hope that helps.